Okay, so we're going to look at infarcts this morning. And as you're aware, when we talk about myocardial infarction, uh, myocardial because it's heart muscle, infarction, when you have death of any tissue, we call that infarction. So infarction is death of tissue. Myocardial infarction is death of the heart muscle. So when we talk about myocardial infarction, we'll break it down into two main types. And we talk about ST segment elevation myocardial infarction and non-ST segment elevation myocardial infarction. So we those are the two categories of myocardial infarction. So one is ST segment elevation, and then the other is non-ST segment elevation. And as the name suggests, ST segment elevation myocardial infarction, or STEMI, the ST segment is elevated. And then non-ST segment elevation myocardial infarction, the ST segment is not elevated. We can use the EKG, ECG to diagnose the STEMI. Again, STEMI is ST segment elevation myocardial infarction. And we're going to look at how we can use the EKG. Now, I know you have posterior wall, posterior infarct, but let's start with something a little simpler first, and then we'll go back to posterior infarct. We're going to start with something relatively simple. Let's look at the inferior infarct. So when we talk about the inferior infarct as an inferior heart attack, the inferior leads are leads 2, 3, and AVF. The inferior leads are leads 2, 3, and AVF. When you look in the inferior leads, you can see that there's ST segment elevation. Just look, you can see that the ST segment is elevated above your PR segment. As a matter of fact, it's probably about 6 millimeters. The elevation is about 6 millimeters. So when you look in the inferior lead, the ST segment is elevated, and we call this an inferior wall STEMI, inferior wall ST segment elevation myocardial infarction. The definition for an ST segment elevation infarct is when you have one or more millimeter of ST segment elevation in 2 or more contiguous leads. So for the inferior wall, the contiguous leads are leads 2, leads 3, and AVF. So these are the inferior leads. So you need to get ST segment elevation of at least 1 millimeter in 2 of those leads. So it's either leads 2, 3, or 3 AVF. Again, the definition for STEMI, ST segment elevation myocardial infarction, you need at least 1 millimeter of ST segment elevation in 2 or more contiguous leads. And of course, the patient is going to have chest discomfort. And when you do the blood test, the enzymes will be positive. So this is an inferior wall STEMI. Okay. Again, the inferior leads are 2, 3, and AVF. And when you look in the inferior leads, you see the ST segment is elevated. Okay. Now, we also have non-ST segment elevation myocardial infarction. And the reason why we separate them into ST segment and non-ST segment, the treatment is different. The treatment is different. So again, when we talk about infarction, we talk about death, and then myocardial infarction means heart muscle death. Okay, so that's why we call a heart attack myocardial infarction. Now, for your anterior STEMI, or your we usually, you know, this is an anterior lateral, really, but the pure anterior lead is V1, V2, V3. So these are either, we usually call them anterior septal leads, and then V4, V5, and V6 are the lateral leads. So when you have ST segment elevation, so if you look in V1 all the way through V5 and V6, you can see that there is more than 1 millimeter of ST segment elevation in these leads. So if it just stop at if you had the ST segment elevation and it stopped at V3, then this would be an anterior septal. But if it goes all the way to V6, it's anterior lateral. Okay, so your anterior septal leads is V1 through V3, and then your anterior lateral goes all the way to from your V1 all the way to V5 and V6. Again, it's a STEMI. STEMI stands for ST segment elevation myocardial infarction. So when you look in the anterior lead, if you have ST segment elevation of at least 1 millimeter, then you have anterior or anterior septal or anterior lateral STEMI. Okay, so again, so those are your anterior lateral leads. The reason why we separate STEMI from non-STEMI is the treatment. The treatment is different. All right, let's look back at the other. So the two main categories of heart attack is your inferior wall and your anterior wall. However, you can have what we call a posterior wall heart attack. And the posterior wall heart attack usually involves the left circumflex and it loops around the back of the heart. And you usually have a posterior wall infarct, STEMI, in the setting of an inferior wall heart attack. So if you have an inferior wall heart attack, of course, we talk about ST segment elevation in leads 2, lead 3, and AVF. And then you have prominent R waves in V1 and V2. And you might have some ST segment depression in these leads. This is a posterior wall infarct, posterior wall STEMI. So again, the treatment is different from a non-STEMI, okay? So one type of posterior wall infarction is when you have infarction in the inferior leads, okay? And you have prominent R waves in V1 and V2, suggesting that the anterior forces are dominant because the posterior forces are reduced. So that's a posterior wall infarction, okay? Another type of posterior wall infarction is, this is the classic type, ST segment elevation in the inferior leads. So you have an inferior wall heart attack, prominent R waves in V1 and V2 with ST segment depression, okay? So that's probably the most common type. Sometime you will have just significant depression in the in V1 and V2, and you might not see anything that looks like ST segment elevation, but it's a posterior wall infarct, and it is treated like the other type of STEMIs. So remember, STEMIs are treated different from non-STEMIs. All right, so the other special type of infarction that you'll see is what we call an RV infarct, right ventricular infarct, and this is a STEMI. All right, so what you're going to see, the patient going to have ST segment elevation in the inferior lead, so they have an inferior wall heart attack. ST segment elevation of at least 1 millimeter in the inferior leads, which are leads 2, lead 3, and AVF. You can see that the ST segment is elevating these leads. But when you look in leads V1, uh, you might get and even V2, you might get ST segment elevation in leads V1 and V2. RV infarct is a very important heart attack because just think about it. If the right ventricle is infarcted, that means the heart muscle dies. So the right ventricle is not going to be able to pump sufficient blood into the pulmonary circuit for it to go to the lungs because the right ventricle is weak from the heart attack. If it's unable to pump sufficient amount of blood into the pulmonary circuit and through the lungs, then the cardiac output is going to fall, right? The cardiac output is going to fall and the patient is going to become hypotensive. In about 1/3 of all inferior wall heart attack, you'll get an RV infarct. 1/3 of all inferior wall heart attack, the patient will have a RV heart attack. And as I mentioned before, the heart muscle dies, it's weakened, and it's unable to pump blood from the right side of the heart to the left side of the heart. So the cardiac output falls and the blood pressure will also fall. The importance of the Harvey infarct is the treatment. Usually when patients have a heart attack, we treat them with nitroglycerin. We give them Lasix to remove excessive fluid because they may be short of breath. The thing about a Harvey infarct, because you're not getting sufficient blood going to the lungs, the blood pressure will be low, and when you listen to the lungs are clear, and the patient will be hypotensive. And if you give them nitroglycerin, IV nitroglycerin, you're going to make them worse. You can hasten the patient demise. So the treatment is different. When you have someone with a Harvey infarct, and if they're hypotensive, one of the first things you're going to do is give them fluid. Which is not what you normally do. When someone have a STEMI, and especially if they're hypotensive and they're short of breath, you're gonna, give them Lasix, a diuretic, and you're gonna, do other things. With someone with an RV infarct, you're not gonna do those things. So that's why you need to know if the patient have a RV infarct. So if they present with an inferior wall heart attack, you need to remember that 1/3 of these patients are going to have an RV heart attack, and you have to make the diagnosis. We can manipulate the ECG somewhat to make that diagnosis of RV infarct, because if you treat them incorrectly, you can kill the patient. So again, with a normal STEMI, you're going to give Lasix, you're going to give nitroglycerin and stuff. You cannot do those things in a patient with a Harvey infarct because the Harvey muscle is weak. So if you remove fluid from the vascular system by giving them diuretics, or if you give nitroglycerin, which reduce venous return, blood going to the heart, the blood pressure is going to fall and you can kill the patient. So how you diagnose RV infarct, you have to put the ECG leads a little bit different. And we talk about a V4R. So you're going to line up the ECG. Let's show you how to do that. So you're going to put the ECG like that. So this would be your V1R, okay? Your V2. So you just put them on the opposite side. So V1R is going to be on the left side, V2R, right, V3, V4, V5, and V6. You put the leads on the right side, okay, as opposed to your normal placement on the left side. And then when you look in leads V4R, you get ST segment elevation. Okay? So with your V4R, you get a ST segment elevation in V4R. As a matter of fact, you get SE segment elevation in most of the right-sided leads, especially V4R. So the patient presents with an inferior wall heart attack with ST segment elevation in leads 2, 3, and AVF. One third of these patients are going to have an RV infarct. What you do, you switch your leads around and you put your leads on the right side, and you want to look at your V4R. The V4R will have ST segment elevation, and this will make the diagnosis of RV infarct. The reason why you want to do that is because if the patient has a RV infarct, the right ventricular muscle is going to be dead. It's not going to be able to pump sufficient blood through the lungs and into the left side of the heart. You don't want to give these patients medications that are going to remove fluid from the system. You don't want to give them IV nitroglycerin or sublingual nitroglycerin because it can make them worse. Okay, so there's an RV infarct. So we look at our inferior wall heart attack, okay, where you have ST segment elevation in the inferior leads, okay. These are STEMIs now, ST segment elevation myocardial infarction. So it's an inferior wall STEMI or inferior wall heart attack, inferior wall infarct, ST segment elevation in leads 2, 3, and AVF. These are the inferior leads. And then we talk about the anterior infarct, ST segment elevation in V1 through V3, or if you go all the way through V5 and V6, then that's a lateral lead, so the anterior lateral, where you have to have ST segment elevation of at least 1 millimeter in 2 or more contiguous leads, okay? So that's your anterior lateral STEMI. Now, as I mentioned before, you can have a heart attack without ST segment elevation, and we call those non-STEMI. So you can have a heart attack and the ECG may be completely normal, or you may just have ST segment depression, or you may have T-wave inversion. Those heart attacks are what we call non-STEMI, non-ST segment elevation heart attack. The treatment between a STEMI, ST segment elevation myocardial infarction, and a non-STEMI is different. The treatment is completely different. All right, you need to know that. All right, so we're going to move on now to bundle branch block. So when we did the conduction system, in the AV node, sorry, at the AV junction, we have the AV node. The AV node go on to the bundle of His, and the bundle of His divides into a left bundle branch block and a right bundle branch block. We had mentioned that the left bundle has 2 fascicles. The left bundle has an anterior fascicle and a posterior fascicle. Okay, so you know where the right bundle is a single bundle, single bundle. So you can have a left bundle branch block. When we discuss the normal conduction system, we said that the impulse travels from the SA node through the atrium, it slows in the AV node, then it travels through the bundle of His, it travels to the left bundle first and then the right bundle after. The left bundle can be blocked. The electrical impulse going through the left bundle can be significantly slowed and blocked, where you don't have any impulse traveling through the left bundle. And how we make that diagnosis on the surface ECG, the QRS duration, the widening of the QRS is usually greater than or equal to 120 milliseconds. And when you look in leads V5 and V6, you have what we call a RSR prime pattern. And I'm going to show you what that looks like. You get a RSR prime pattern in lead V5 and V6. Or if you look in lead V1, you'll get what we call a QS pattern, or a RS complex. And this is what we mean by that. All right. So this is V1, so you'll get a tiny r, and we represent that by a lowercase r, and then you'll get a big giant S wave, and we represent that by uh, a capital S. So when you look in V1, you get a tiny r, a big S, okay? Or when you look in V5 and V6, you get this R prime. You get two upward deflection, all right? It's again the duration when you check the width of the QRS. So this is the width of the QRS. You can see it's one tiny block, two tiny block, three. It is more than three tiny blocks. Remember that each tiny block is 40 milliseconds, 40 milliseconds. So three of them is a little bit more than three. It's more than 120 milliseconds. So the diagnosis of a left bundle branch block, that is the impulses block in the left bundle, you're gonna have this R prime in V6. So this is our 12 DDKG. V6 is over this side. Okay, so and it's not uncommon to just get a broad monophasic R wave in V6. Okay, but when you look in lead V1, you get a tiny R and a big S. Okay, so this is your classic left bundle branch block. Okay, a broad bizarre, sorry, a widened QRS complex, and you can see V6 is monophasic, and sometimes you'll have the har prime. Okay, but when you look in V1, you have a tiny har and a big S, so that's a left bundle branch block. Now, just like how the left bundle can be blocked, you can get a right bundle branch block. And the right bundle branch block, the same thing, the QRS duration, the width of the QRS is going to be greater than or equal to 120 milliseconds. And when you look in V1, you'll get the RR prime or different configuration of that. And then in in leads 1 and AVL, you get slurred S wave. And this is what it looks like. So when you look in V1, we talk about a rabbit hairs. So V1, you're going to get a R prime. So the first har we call a har. If you get a second har, it's a har prime. And the first har is usually smaller than the second har, okay, in height. So when you look in V1, you get a har prime, and the duration of the QRS is going to be greater than or equal to 120 milliseconds. And when you look in V6, you get your tiny har, okay, sorry, a tiny Q. All right, so the first downward deflection is a Q. Then you get a big R and a small S. So this is how we represent it. As when you look at the Q, it's a lowercase q because it's a small q. The R is big, so you get a capital R. The S is small, so a lowercase s. So this is your classic right bundle branch block. So V1, you have your R prime. Remember that the R is usually smaller than the R prime. Or if you look in V6 you get a small Q, a big S, and a small S. But just remember that with a right bundle branch block, when you look over the right leads, you're going to get the rabbit here, or the R prime. With a left bundle, because it's over the left side, you're going to get your R prime over the left sided leads, which is V5 or V6. Okay, you have to know the classic definition for these bundle branch. So you can have a left bundle branch block, and you can have a right bundle branch block. Now remember that the left bundle has two fascicles. It has a anterior fascicle and a posterior fascicle. These are just branches. So The left bundle has two branches. It has an anterior fascicle and a posterior fascicle. And each of those fascicles can be blocked. So if the anterior fascicle is blocked, we call that a left anterior fascicular block. And there's a specific definition for that. With the left anterior fascicular block, you're going to have an extreme left axis deviation. Okay? So remember, you have to do your axis. All right? So to do the axis, you're going to look in your limb leads. You're going to find the lead that is most isoelectric. And if you say, let's say the most isoelectric is, let's say it's AVR. AVR. If remember, you're supposed to have your cheat sheet with you. So I'm not gonna, you know, if AVR is the most isoelectric, perpendicular to AVR is lead 3. Remember, lead 3, if it's positive, subtends an angle of plus 120. Lead 3 is negative, however, so it's going to subtend an angle of minus 60. Again, if you have extreme left axis, that is left axis deviation more than minus 30, usually more than minus 45, then that will clinch the diagnosis of left anterior fascicular block. And you usually have tiny R waves, in leads 2, leads 3, and AVF. All right. Let me just draw it because you guys don't believe me when I say you need to walk around with these things. I mean, you need to be revising your. All right. So again, this would be lead 1. Okay. Okay. This is the AVF. Okay, and only you can do this. I mean, if you don't walk around with your cheat sheet and use it, I can't do it for you. So this is AVF, lead 3. Is right here, lead 3. Lead 3 subtends an angle of plus 120. AVR is right here. Positive AVR is right up here. It's minus 150. Okay, so when we look in our limb leads, the most isoelectric we say is AVR. Okay, we say that AVR is perpendicular to lead 3. AVR here perpendicular to lead 3. Okay, so the axis, if lead 3 was positive, the axis would be plus 120. But lead 3 is negative. The majority of the deflection is downwards. So a negative lead 3 would be right over here, and it's minus 60. Okay, it's minus 60. So we said to diagnose a left anterior fascicular block, the left axis deviation has to be greater than minus 45. So this satisfies that criteria. In addition to the axis being greater than minus 45, you're going to have small R waves. Remember, the R wave is the first upward deflection. You're going to have small R waves in leads 2, lead 3, and AVF. So this is your left anterior fascicular block. That is how you diagnose the left anterior fascicular block. Okay, extreme left axis and small R waves in the inferior leads. Okay, that means just the anterior fascicle is blocked. All right, so now you know how to diagnose that. You have to walk with your cheat sheet. All right, so again, the left bundle has an anterior fascicle and it also have a posterior fascicle. To diagnose a left posterior fascicular block, you're going to have extreme right axis deviation. The right axis is usually greater than plus 120, and then you have small R waves and deep S wave in leads 1 and AVL. So you're going to have small R waves in leads 1 AVL and deep S wave in the same leads. And when you look in the inferior leads, you're going to have tall R waves. So remember, when you had a left anterior fascicular block, you had small R waves. With a left posterior fascicular block, you're going to get tall R waves in your inferior leads. And this is what it looks like. So let's do your axis again. You look in your limb leads, okay? Look in your limb lead, the most isoelectric, you can, okay, the most isoelectric, you can say AVR again. All right, so if you use AVR, perpendicular to AVR is lead 3. Remember, your perpendicularity is like this. Lead 1 is perpendicular to AVF. AVR is perpendicular to lead 3. Lead 2 is perpendicular to AVL. So if we say AVR is the most isoelectric, perpendicular to AVR is lead 3. Lead 3 subtends an angle of plus 120. It is positive, so the axis is plus 120. So to diagnose so it's either equal to or greater than 120, and you're going to have tall R waves in the inferior leads, small R waves in leads 1 and AVL. So again, let's look in your inferior lead, which is leads 2, lead 3, and AVF. You have tall R waves. R waves are tall. And when you look in lead 1 and AVL, you have tiny R waves, but a deep S wave. So you have extreme right axis deviation to 120 or greater. You have tall R waves in the inferior leads, small R waves in leads 1 AVL and deep S wave. So that satisfies the criteria for your left posterior fascicular block. Okay. All right. Now, as we mentioned before, we can the ECG, EKG is very important to assist us in determining if your pacemaker is functioning properly. And someone come to us, and if the pacemaker is not functioning properly, we can look at the ECG and make that determination. But first of all, you have to know what a pacemaker rhythm looks like. So usually with a pacemaker, you'll get a spike, because you put a pacemaker in because the conduction system the electrical system of the heart is not working properly. So you put your pacemaker in, and you're going to give the electrical current to the heart. So the electrical current is usually let's look at this rhythm strip at the bottom. The electrical current is going to be depicted as spikes. So you can see a spike there, a spike, a spike, a spike. That means your pacemaker is putting out an electric output. Okay, so electrical output is being applied, and after the electric output, then you see a white complex. Electric impulse, white complex. Electric impulse, white complex. Electric impulse, white complex. So you have a pacemaker spike, denoting that electrical power is being supplied to the muscle, and then the muscle contracts. So when you give the electric impulse, you have depolarization, and that is depicted by the white complex right there. And it's wide because you're supplying the energy to the muscle, to the right ventricular muscle. And when you stimulate the ventricles, it's usually a wide complex, and that is why pacemaker beats are usually wide, because we supply the energy to the ventricular muscle. But you can see every spike is followed by a QRS, every spike is followed by the QRS. So you supply the energy to the muscle and it captures, okay? And the muscle is stimulated and the muscle contracts. So you can see that you have the pacemaker spike before the QRS. So this is a ventricular pacemaker, okay? All right, so this, we usually put the pacemaker lead in the right ventricle, and the output, the energy output comes from the pacemaker. Electrical energy is supplied to the ventricular muscle, and you have depolarization of the ventricular muscle, and then it contracts. You have the QRS. All right. So pacemaker spike followed by the QRS. All right. So you can also have an atrial pacemaker. All right. So, and if you look on this now, you can have an atrial pacemaker. You can see that before. Let's look at the rhythm strip. Before you get a P wave, you have a little spike. So before each P wave, there's a little tiny spike, little tiny spike, little tiny spike. All right. So what's happening if the SA node is not working properly? If the SA node is not working properly, then you just need to supply energy to the atrium, the right atrium. And if you supply energy to the right atrium, which you can see is depicted as these little spikes, then the atrium is going to be depolarized, and then you'll have contraction of the atrium. The impulse will travel down through the atrium to the AV node, and then once it gets to the AV node, it's gonna cause stimulation of the AV node, the bundle of His and the bundle branches. The complex is narrow. Okay, you can see that the complex is narrow because the impulse originated in the atrium. If the impulse originated in the ventricle, then it's going to be broad. The complex is going to be wide. So with an atrial pacemaker alone, you stimulate the atrium, you have atrial depolarization, then the impulse travel to the AV node, stimulates the AV node, the bundle of His and the bundle branches, and you get a narrow complex because the impulse originated in the atrium, as opposed to this complex is a ventricular pacemaker. The impulse originated in the ventricle, okay? So you stimulate the ventricle directly. So you can see the spike, and it's followed by a wide QRS complex, okay? The atrium is not involved in all of this, right? So these are pacemaker spikes. We're gonna stop here. Um, the next session we'll look at how we can use the ECG to look at atrial and ventricular size.